It's my pleasure duty to introduce Padmashri Venkata S.Ram, who is going to talk on the hypertension guidelines through the kaleidoscope. He is a senior consultant and chief academic officer at Apollo Hospitals, Hyderabad. He is also the director of Texas Blood Pressure Institute, Dallas. And he serves as the vice president, American Society of Hypertension, and director for South Asia region, World Hypertension League, and contributed to more than 420 articles. Over to Dr. Venkata S.Ram.
Thank you very much. Good morning, ladies and gentlemen. C.Ram. I will not talk too much about guidelines because one more guidelines, I just got a message, whether we like it or not, you have to wait till August 16th after the Independence Day. So I will talk few things on hypertension. Somebody asked me, are you going to say anything about diabetic hypertension? I just changed my slides because I met a number of doctors at the Hyderabad airport who gave me that input. So I'm going to cover a few aspects of it. Very quickly, ladies and gentlemen, the burden of cardiovascular disease in this country is enormous. If you look at 10-year expenditure for cardiovascular disease, it comes to 20,000 lakh crores. So that translates to 20,000 lakh crores spent on treatment of complications of metabolic risk factors. When you think about the cost of medications is always very small, 10%. 90% of the costs are for complications related to cardiometabolic disorders. Very, very important to know. Unfortunately, despite growing economy, unfortunately, despite growing obesity, our cardiovascular disease has also gone up of all the regions in the world. If you look here, when they say SARC, don't be fooled, it's India. The only data are from India. SARC is a very diplomatic word, but it is India. So in India, the cardiovascular disease is actually going in the wrong direction. Because of some people asked me to say a few comments on diabetes and hypertension, I will say a few things that you already know, but I am going to reinforce what you already know. One characteristic of hypertension and diabetes is they have nocturnal hypertension. If you see here in this slide, you will notice that even in normotensive diabetics, there is no nocturnal drop in blood pressure. So they are asleep, but their blood pressure is very much awake. So important to know, nocturnal hypertension is a characteristic of diabetes hypertension. Central aortic blood pressure, which is the determinant of cardiovascular prognosis. Central aortic blood pressure is higher in diabetics compared to those who don't have diabetes. So you might take their blood pressure peripherally, it may not tell you the story, but the central aortic blood pressure is very high in patients who have diabetes both during daytime and nighttime. This is an experiment showing as the glucose concentration increases, there is activation of renin-angiotensin system. So when you look at glucose experimentally, incremental glucose causes activation and agitation of renin-angiotensin system, which is vasculotoxic. This is a very interesting slide looking at the kidney in diabetes and in normal. You will notice the diabetic kidney is overpopulated with renin-angiotensin system in contradistinction to normal kidney. ACE levels and angiotensin levels are very, very high in a diabetic kidney, and that is the main problem for the onset and progression of CKD in patients who have diabetes. One thing that happens is as the glucose level goes up, there is increased superoxide, and that can be vasculotoxic. In patients who have diabetes, there is increased superoxide generation, and therefore they are not able to vasodilate. So they are not able to vasodilate, continued vasoconstriction. That is the reason why in some patients who have diabetes, who have acute coronary syndrome, coronary angiogram might look normal. But if you look at this slide, they are unable to vasodilate. So these are some of the characteristics of diabetes and hypertension. Now let me go through a kaleidoscope of drugs in hypertension now and what you can expect in the next 5 years. The most important characteristic of this slide is the mechanism of action of diuretics in hypertension is not diuresis, not natriuresis. Very, very important to know. Diuretics lower the blood pressure by decreasing peripheral vascular resistance. You will notice on the slide, the blood pressure goes down, plasma volume and cardiac output become normal, but the peripheral vascular resistance remains low. So take-home message for all of you is the mechanism of action of diuretics is not diuresis, not natriuresis, but a fall in peripheral vascular resistance. Why am I saying this in year 2025? Because there is some new information on diuretics. This is an old study that we did long time back, looking at the fall in blood pressure with hydrochlorothiazide or chlorthalidone long time back with my late partner Norman Kaplan. We showed that with chlorthalidone, there is a greater reduction in blood pressure. Now, what is this in 2025, what I'm talking about? There are two major publications, ladies and gentlemen, last year, which have resolved the controversy between hydrochlorothiazide and chlorthalidone. New England Journal of Medicine and JAMA Cardiology. Very, very high impact factor. The studies published in these papers have shown a comparison, only study to compare head to head between hydrochlorothiazide and chlorthalidone, and no other study has done it. You will notice the blood pressure response, hydrochlorothiazide, chlorthalidone is very similar. Potassium is very similar. So when you give hydrochlorothiazide or chlorthalidone, the blood pressure effects are similar, potassium is similar. You can't tell which drug the patient is taking. But according to these papers, patients who were taking chlorthalidone, they had lesser complications compared to hydrochlorothiazide. First time, a head-to-head study has shown that chlorthalidone has a superior efficacy in reducing cardiovascular outcomes compared to hydrochlorothiazide, and they have shown that the incidence of heart failure and other complications are significantly less in the chlorthalidone group. And in May, FDA has first time released low-dose chlorthalidone for the treatment of hypertension. They have never done it for 60 years. But based on these two studies, they have now approved low-dose chlorthalidone for United States. Now, the debate over the choice of diuretics is over, based upon these papers, suggesting that chlorthalidone type of a diuretic is superior to hydrochlorothiazide in head-to-head comparison studies. Now, let me talk about few things of interest to you: artificial intelligence and hypertension. And this is the definition of artificial intelligence according to the nomenclature, is that you have some degree of autonomy, but you are also controlling other factors. So hypertension is poorly controlled. You give the same drug to two people, one person responds, the other person does not. It happens all the time. So what is this? Same drug, same dosage, but different responses. And this is where I think AI is going to tell us very poor response for blood pressure control. The number of publications on artificial intelligence and hypertension is just skyrocketing, skyrocketing, skyrocketing. Every day, more and more publications. The reason now is when you apply artificial intelligence for the early detection and management of hypertension, you consider various demographic factors, you consider social factors, you consider the laboratory factors. When you put all of them together, it will give you an algorithm which drug might be better for such a patient. So in the future, AI might direct you to select appropriate drug based upon a number of factors on which you can make a decision. So very, very interesting. So ladies and gentlemen, artificial intelligence is going to, in the future, is going to tell us a little bit about risk prediction, diagnosis, management, and importantly, as a treatment guide, how to select, which combination to select. Now, there are already few data. I'm going to show 1 or 2 published, and I'm going to show 2 or 3 unpublished sent to me by authors, so we'll keep that confidentiality. So using artificial intelligence, you will be able to predict the cardiovascular risk of patients at the given level of blood pressure. At the given level of blood pressure, what would be the complications based upon the artificial intelligence models that I'm going to show some of them. According to this artificial intelligence one model, in one study, they were able to predict the future occurrence of heart failure, acute MI, stroke, and CKD. If you can do that, then it will allow us to be very, very specific medicine, so-called precision medicine. If this continues, we don't know, we have to see. So ladies and gentlemen, one thing that is happening rapidly is cuff-left devices for blood pressure. And we are working with ADKIA now to develop where you have a cuffless blood pressure and that is transmitted to the sensor and that is stored, and then the blood pressure is recorded properly. And this is how it traces from the body to the sensor, signal, model, and the output. And the output you are looking for with wearable device is the blood pressure, 24-hour blood pressure, beat-to-beat blood pressure. Very, very important. Ladies and gentlemen, this is one example where application of artificial intelligence in patients with hypertension, well controlled or uncontrolled. When you use non-pharmacological therapy, you put multiple factors, you will see there is a significant improvement in the blood pressure by using the parameters that were derived by artificial intelligence. But one thing, let me assure you, ladies and gentlemen, there is nothing like clinical judgment. There's nothing like clinical judgment. Look at the first bar, expert. Look at the second bar, GPT, then Gemini. When you look at all these models, the best predictor in a clinical setting ultimately is going to be your judgment. So we do not know where we are going, how we are going, but one thing that we have to be aware of at the present time, we do not know the ethical aspects of it. Who is the owner of this data? The healthcare provider, or the patient, or the AI vendor? Who is the proprietor of this data? We collect, we curate, and we disseminate. But who is responsible for this? And this has not been tested legally, and we have to wait and see. So this is what Bill Gates has said. It must be managed carefully to ensure the benefits outweigh the risk. Very, very important, we have to use this. And ladies and gentlemen, artificial intelligence will not replace physicians, but physicians who use artificial intelligence may very well replace those who do not. So keep that in mind. Now let me turn to 2 or 3 drugs. One of the drugs that has been approved in US last year is endothelin antagonist. Endothelin is the most powerful vasoconstrictor in human pathophysiology. It is 1,000 times more vasoconstrictor than non-adrenaline. And this is something I had written for many years ago, but I never expected endothelin antagonists to be approved. Endothelin antagonists block endothelin A and endothelin B receptor. When you block it, there is profound vasodilatation. So the characteristic of the new endothelin antagonists is they block endothelin A and B, therefore there is sustained vasodilatation. And that is what happens with endothelin antagonists. And endothelin antagonists have been shown to cause a remarkable reduction in blood pressure in people with resistant hypertension. and they are approved in, at least in US. I do not know the status in India, but it could be a useful drug for India if it is approved. Now, the new molecules that are emerging, that are being developed so rapidly, I have never seen in my life. Such a rapid development. And they are likely to be approved, maybe in my own lifetime, in the next 4 to 5 years. The drugs that block angiotensinogen, the drugs that block aldosterone synthase, and the drugs that can also manipulate angiotensin metabolism, and I'm going to discuss one. So this is the cascade of the renin-angiotensin system that all of you know. The new drugs are now targeting angiotensinogen by RNA interference, and to see what happens to the blood pressure. You can block aldosterone synthase, not aldosterone antagonist, but synthesis of aldosterone is decreased, whereby the blood pressure comes down and heart and kidney are protected. One drug that is knocking on the doors of FDA, literally knocking, is a drug called zilebesiran, which is an mRNA interference substance. It blocks angiotensinogen where it matters the most. At the generation level, when you want to do something, you must stop the train at the station, not on the track. Zilebesiran stops the train at the station before it leaves, because it blocks mRNA interference with angiotensin, a remarkable drug. Studies have shown in animal models it causes significant fall in blood pressure, but that doesn't help us. What about human beings? There is a remarkable study published in New England Journal of Medicine. Different doses of zilebesiran, a single subcutaneous injection, lowers the blood pressure for 6 months. And remarkable, really remarkable, I'm showing you this one. This is the human study in New England Journal of Medicine, different doses of zilebesiran compared to placebo. Placebo you see on the top, no response to the blood pressure, but different doses of zilebesiran for up to 6 months, there is a significant drop in blood pressure. The question that you will ask me is, what happens if somebody has unwanted degree of hypotension? What do you do with it? Now they have now developed drugs that reverse the action of zilebesiran. So you don't have to be afraid that you are causing the patient to have significant hypotension. You can reverse it. I'll show you the data. So these are the data showing that with zilebesiran, there is a significant fall in blood pressure. But if it is too much, then you can reverse it with a substance called Reversal. So it has got a long duration of action, but it is also reversible. So FDA has to release 2 drugs at the same time that lowers the blood pressure and that reverses the action of blood pressure. It has never happened before that 2 drugs that antagonize each other have to be released, and this is very, very exciting development in the field of hypertension, and let us see what happens. Now, last thing that I'm going to discuss is aldosterone synthase inhibitor. Aldosterone antagonism, all of you know, but if you block aldosterone production, then it could have significant hemodynamic effects that are very, very important. I'm going to show you some data. There are 2 or 3 drugs now that are being developed, and they are also knocking on the doors of FDA for release. So one is called baxdrostat, aldosterone synthase inhibitor, remarkable fall in blood pressure. And there is another drug, significant drop in blood pressure, and no adverse effects like aldosterone antagonism. No adverse effects, no hyperkalemia, no gynecomastia, no GI intolerance. So this is also likely to be approved in our lifetime. So ladies and gentlemen, the new molecules that are emerging for the treatment of hypertension, they are blocking the pathophysiological mechanisms that rise the blood pressure. And I have shown you 3 drugs, endothelin antagonists. I talked about zilebesiran. I talked about aldosterone synthase inhibitors, very, very interesting drugs. So, Mr. Chairman, ladies and gentlemen, in conclusion, no matter what you do, try to achieve the blood pressure as close to 130 or 80 as possible. I am not going to say do it tomorrow. As close as possible, you should try to reach it. Because when you're driving a car, you want to reach the destination, right? You don't want to stop in the middle. You have to go somewhere. So you should always treat hypertension the way you prepare to go to the airport. You don't want to delay, right? You will miss the plane. Same thing when you see patients with hypertension. Don't delay the treatment. Do appropriate treatment. Luckily for hypertension, it comes with a long fuse. The fuse is very long, and those are the visits of the patient to your office, and you can diffuse it during any of those visits. Mr. Chairman, ladies and gentlemen, thank you very much for your attention.